And now we move on to, so it's very clear that we need not worry, and it's a mild infection. But last time it was very severe, and so we have Dr. Bansidhar to explain what co-infections occurred in the previous outbreak, and also to explain in a way that should anything happen, what is our preparedness. So it is to share with you the the ability that we have to quickly diagnose if there are severe infections. Dr. Bansidhar, who's now the director of microbiology and molecular biology and infection control in Max Group of Hospitals, and has done excellent work on co-infections. Dr. Bansidhar, please. Next slide.
Thank you, sir. Thank you, Dr. Rattan sir, and thank you, Dr. Ekta, for inviting me for this lecture. I could not open my video because maybe the host has to allow me. Uh, Now let's go to like what Dr. Rattan sir has said. The basic what we follow in our hospital is the mask and hand hygiene. These two are basic things which we follow in this COVID preparedness. And now next slide, please. This chart I'll show you at the end, and I think next, please. Right. So if you see, because of time constraint, so I'll quickly go through the co-infection and super-infections. We all know it is a co-infection is a simultaneous presence of COVID-19 and other microorganisms. Whereas super-infection means after COVID, you have other microorganisms which is super added after admissions in the hospitals or patients who are with immunosuppression treatment in the hospitals. So superinfections are associated with higher morbidity and mortality, and there is need for vigilance for monitoring of this infection. Next slide, please. But if you see scientifically term, co-infection can be defined as the recovery of other pathogens in a patient with infection within 48 hours of admission or within 48 hours of detection of COVID. Whereas superinfection occurs when a patient has a clinical signs and symptoms of pneumonia or bacteremia combined with positive cultures or new pathogens from the lower respiratory tract or blood specimen obtained after 48 hours of admission or after 48 hours of detection of COVID. In other words, co-infection occurs simultaneously with the spread of microbe, whereas superinfection develops after the initial infection. However, both the terminology are so correlated and they overlap, so sometimes we cannot differentiate what is co-infection and superinfections. Next slide, please. Yeah. What is the importance of co-infection and superinfection? Because when you have COVID and then associated with other superadded or co-infections, then there will be an increased disease severity and there is a higher mortality rates. So overlapping symptoms make it difficult to distinguish in COVID and other infections. And there is a, if you delay in identification, that may actually difficult to manage the patients and the patient stay and the outcome will be severe. Next, please. So we have a different study. We have analyzed the meta-analysis of many paper also. There is different prevalence according to the different countries and different seasons. And if you see around 19% of COVID-19 patients developed co-infections present at diagnosis, whereas 24% developed super infections. But the very prevalence, I'll go on the next slide. Then if you see impact on mortality, previous slide. Yeah, but if you see the impact on mortality, the presence of co-infection or super-infection, there is an increase in mortality risk, and ICU patients with this infection have mortality rate of 50, more than 50% in compared to without any super-infection co-infections, only COVID. And we know what is the common pathogens. Bacterial superinfections mainly occurs in ventilator pneumonia and bloodstream infections. These are the two important where these MDR microorganisms are come up. And then we have fungal infections, mainly invasive pulmonary aspergillosis, in occurs in mainly in immunosuppressed patients or severe immunosuppression patients. Next slide, please. So this table will show you what is the how the prevalence across the globe. So if you see bacterial co-infections, it is very less, whereas bacterial super-infection is more. Bacterial co-infection is only 2 to 3%, 2.3%, where bacterial super-infection it can go up to 45% in, and in pneumonia it is 50%, and bloodstream infection is 34%. Viral co-infection is higher in compared to bacterial co-infections. It is around 14%. Viral co-infections with other viruses. If you see influenza, we have Dr. Nivedita has widely explained, and Dr. Varsa also. My data is also, which I'll present at the end. It is clear cut the influenza is the major problem, not the COVID-19. And if you see other co-viral infections, but as Dr. Nivedita has presented many things, but there are some other rare viruses coming up which will show like para-influenza and other viruses, few viruses. I think they have to incorporate in the ARA like acute respiratory pathogens surveillance. And then fungal super infection is 6.3%. Some fungal infection in ICU, there is an increased risk with corticosteroids and immunosuppressions. If you see COVID co-infection is very low, and COVID's co-infections, if you see outcome, there is a higher hospitalization, mortality, and prolonged recovery. Co-infection in non-ICU is around 29%, co-infection in ICU is 16%, super infection in ICU is 41%, and super infection is 20%. So there are a lot of variations in the prevalence of co-infection and super infection with COVID. Next, please. So here, if you see on global and country-wise, if you see here, the bacterial superinfection in China is 42.2%, and Spain, the bacterial superinfection is 4.7%, mainly Pseudomonas and E. coli. UK bacterial superinfection is 9.3%, and mainly the coagulase negative Staphylococcus. If you multi-country incidence, bacterial superinfection is 14 to 24%, and varies according to the region and according to season. And UK's fungal superinfection is 21%, mainly the Candida species. Next, please. So here, if you see our Indian data, the prevalence of superinfection, there is a 13% in hospitalized patients superinfection in AIMS Delhi study, and 83% are ICU admitted patients. Common type of superinfection are bacterial infection, fungal infections, viral and co-infections. Common bacterial pathogen, if you see Klebsiella, Acinetobacter, E. coli, which we commonly found in our ICUs. Common fungal pathogens is Candida, Mucorales, and less viral co-infection, less commonly reported in various Indian studies. Risk factors is, as even Dr. Khilnani also said, the advanced age, diabetes, prolonged ICU stay, mechanical ventilation, steroids. These are the risk factors in the COVID. And outcome, if you see higher mortality and longer hospital stay, increased healthcare resource use, all these are important factors in COVID-19 superinfection. Next, please. So even outcome is also worse with co-infection and superinfections. Yeah, mortality is 3.3, but if you see mechanical ventilation, co-infected patients have 10%, and super-infected is 45%, and higher in super-infections. Hospital stay, they are longer stay in co-infections. Next. Common bacterial pathogens with the same in bacteria, if you say Klebsiella pneumoniae, Streptococcus pneumoniae, and Staphylococcus aureus, viruses, influenza, and influenza B, RSV. I think and the ICMR data is also showing the same thing. Fungi, Aspergillus species, super infections in bacteria, Acinetobacter, Pseudomonas, E. coli, viruses, rhinovirus is, but super viral infection is less. Fungi, Candida species. Next, please. So if you, this is the organism wise Streptococcus pneumoniae, but I'll not go into details because of time factor. Next, please. These are the fungal infections which we have discussed. There are viral co-infections which also discuss the individually influenza B. The dual infection increases the pneumonia severity and ICU needs. So all definitely, or even parasitic infections which I have not put in the slides, like in the region wise or the season wise also the dengue, malaria also associated with co-infections and super infections in COVID. Next slide, please. Yeah, so I'll sum up the data. I'll show. I've just taken. We are running the BIFAR upper respiratory panels. So I've taken out the data which was there from 1st September 2013 to 5th June 2025, where we have tested 3,986 upper respiratory BIFAR panels, and where we have positive cases is 2,363, and mainly the viruses. So all viruses is there in our community, and because of this multiplex PCR and BIFR or can start, we able to get all these pathogens together. So next slide. So this is the main slide. I think Dr. Varsa and Dr. Nivedita has explained. Here you can see in 2013 and 2000 SARS-CoV is the lowest bottom row. Here, sorry, here in the last row uh, we have COVID cases, and only in these 3 years, 2013 to 2025. 1st September 2023 to 5th June 2000, yesterday data, 5th June data 2000. So we have only 163 get positive in these upper respiratory panels. However, we have tested almost, I think, 4-5,000 tested, 4,000. So maybe this is the very specific patients who are affordable patients who are coming to us in max care and who can pay the price of BIFAR. So we have the data maybe not in the community was Dr. Nivedita, Dr. Vasa's their data, but how it is there, it is looks like similar. Here also you can see in the 2020, the last column, the total data here, if you see the common viral pathogens is still this rhinovirus, and but that is not clinically much significant, very mild. But influenza is the 686 patients, and then we have H1N1 331, then influenza S3N2 199, influenza B 235, Mycoplasma pneumoniae has come up in the last 1 year, has very high number and cases, Mycoplasma pneumoniae, parainfluenza viruses 3, which I also request ICMR to include this strain, which is also coming very high number, and other pathogens is also all viruses is there, and but if you see the COVID, it is only 163 patients in the last 2.5 years. So we have multiple pathogens detections and uh, 2 or 3 viral pathogens, but along with COVID, we get very less co-infections. Uh, Here, this is the last 1st April 2025 to 5th June data. So we have tested only 370 patients, and we have positive 186. But if you see, only COVID is only 13 cases. So there means there are other virus. If you see compared to the pandemic time, 2020-22, the majority are COVID. But here, this resurgence also in 2000, there are other viruses still prevalent. Cases we found mild and very mild. As far as Dr. Jesse Killan said, it is 3 to 4 days fever, but what we get 99% are from home care and collection centers, OPDs. Only in the last 1 week, even only we have 2 patients admitted in Saket and Smart hospitals. So they are mild, very mild, maybe fever of 1 or 2 days, dry cough. And so maybe we should not panic, but yes, as per the government protocols, we have basic, the mask is very important for the healthcare staffs as well as hand hygiene. These are two important things which has to be followed. Next, please. So this is the data. This is the same, sorry, maybe some wrong. 1st April means it is the September 2023 to the 5th June 2025. So there is 31 cases of COVID where we got co-infections, and the co-infections, so the co-infections are very less in this last 2.5 years. And if you see, these are the co-infection positive in these 31 COVID patients in the last 2.5 years. These are the numbers: Mycoplasma pneumoniae in one case, adenovirus one case, influenza B, H3N2 one case, Bordetella pertussis in one case, RSV three cases, human metapneumovirus four cases, and influenza H1N1, and then other coronaviruses, human rhinoviruses, influenza, then parainfluenza 3. So all the viruses, but there are very limited co-infection with the COVIDs. Yeah. So this is the, so why the co-infections and super infections, actually what is the problem is that the most important problem what we got is that antimicrobial resistance. During COVID time, we have, there is a peak of antimicrobial abuse, and there is a huge number of antibiotic being used that time. So that is the concerns where the antimicrobial resistance has increased, not, I mean, the overuse of antibiotics has increased. So that is one more concerns where you got co-infections or super infections. And then that increases the length of stay and the mortality and everything. And we have to main concern our AMS antimicrobial stewardship program, infection control practices in mainly in the co-infections and super infections. Next. So thank you very much, and thank you, Kaho and Dr. Rattan sir, Dr. Ekta, and all of you. Thank you.
Thank you very much, Dr. Bansidhar.